And so we rely heavily on the pathologists, and anyone who's come to see Pam or me here or any of our surgeons, the first person we call is Teri, say, what do you think about this? Is this a sufficient biopsy? Are there additional stains that need to be done? Should we get another biopsy? If this is neuroendocrine tumor, can you tell us exactly what type it is, or can you give us the most information possible so that we can make the right decision as to how to treat? And so, so I'm delighted that Teri gave up her Saturday to come talk to us about pathology for neuroendocrine tumors. Teri.
Okay. Thanks. Looks like we are running behind time, so I'll see if maybe I can catch up a little bit. Okay. All right, so just thanks for the introduction, George. I just wanted to say, in addition to a professional interest, I actually have a bit of a personal interest in neuroendocrine tumors. My mother-in-law was diagnosed with one several years ago, and Pam and George actually treated her. So I'm coming at it from both sides. My subtitle of the talk this morning, I'm obviously going to just talk about pathology and how we go about diagnosing neuroendocrine tumors, is where did all the carcinoid go? And I'm sure I'm mispronouncing that. I studied Spanish and French, not German. But originally when these tumors were identified, and I think it was probably by a combination of surgeons and pathologists, it was thought that these were benign, and the term was the carcinoid, and patients appeared to do well, and it was a sort of a medical curiosity that they seemed to be spreading around, but patients did quite well with them. And then, of course, over the years, we discovered that that's not necessarily true, although some of them are quite clinically indolent. Others can behave somewhat more aggressively. And so there's been a move away from the carcinoid term to this more general neuroendocrine tumor or neuroendocrine neoplasm terminology as a way of distancing, I think, ourselves from the sort of basic misconception that these were, in fact, all benign tumors. So I thought I'd go a little bit over sort of our evolving knowledge, and I'm not shooting all that high. This will be a lot of pictures and I think fairly straightforward stuff to most of you, especially if you've already been hearing you've been to some of these other endocrine talks. But I thought I'd talk about site of origin. As you know, not all of them come from one particular site. Functioning versus non-functioning, I think that you're going to hear a lot about that throughout the day. And then, of course, I'll spend most of my time talking about histology, which is what we do, some of the standard immunohistochemical markers that we use to help make the diagnosis of neuroendocrine tumors. And then I'm going to go over the new nomenclature, classification, and grading and staging that is really pretty new and becoming a much more sort of uniform than it has been in the past. And I think that that's quite good. Certainly a step in advance. So the anatomic site of origin has been historically sort of divided into foregut, midgut, and hindgut. The foregut tumors are the lung, stomach, and duodenum. Midgut or small bowel, proximal colon, and hindgut, not surprisingly, are going to be the colon or distal part of the GI tract. And then, of course, you can get neuroendocrine tumors arising in other organ systems, particularly the pancreas, but you can see them in the adrenal and thyroid. And in some of those latter organs, you often associated with sort of hereditary syndromes. And I think that you're going to hear about that in the next session. So I'm just going to talk mostly about GI endocrine tumors today, because that's really where a lot of the developments in terminology and staging have occurred in the last few years. So this is just a very colorful diagram of the intestinal tract, and that big thing up at the top is the stomach, and then the rectum's at the bottom. And those little colored sort of figures there are just sort of denoting where the most common neuroendocrine tumors arise in the GI tract, and the different colors reflect the fact that not all these endocrine cells are the same. And you can see at the top, sometimes they originally called G cells, L cells, EC cells, because I think much of the original work was done on electron microscopy. But suffice it to say that even if you have a neuroendocrine tumor rising in the GI tract, they're not necessarily the same tumor. It can be, depending on where they arise, they may actually be somewhat different. And this is the same sort of color scheme for the pancreatic neuroendocrine tumors, a subset of which, as you know, can be functioning in patients. Some of you may have one of those that associated with actual hormone levels that cause diarrhea, sometimes diabetes, etc., although a subset are obviously non-functional as well. Now this is the sort of classic histology of a carcinoid tumor. This is what was originally, I think, described. This is kind of going from low magnification when you look under the microscope to a little higher, and then culminating on the lower right quadrant photograph, that's sort of a higher magnification. And these tumors are basically composed of a uniform cell population, often small to medium-sized cells, and that background they tend to be very well vascularized, and those little strips that you see there are the blood vessels. And they have this characteristic sort of what's referred to by pathologists as a stippled or a coarse and fine nuclear chromatin pattern. You've also may have heard some people call it salt and pepper. And you can see it best on the lower right quadrant, where you can see the blue circles are the nuclei of these cells, and you can see that there's larger and smaller clumps of nuclear chromatin. That's the DNA. And that's a fairly characteristic feature of the usual sort of standard neuroendocrine tumor and the originally identified carcinoid. You can get variations. This is pretty easily recognized by most pathologists, and you really don't need to do a whole lot of immunohistochemical stains, and it's not a real stumper to try and diagnose that. But sometimes you can get tumors that can form rosettes. You can get tumors that form these long trabeculae. Others grow in a very solid or organoid fashion, and they don't necessarily have that quite stippled chromatin pattern. They sort of show a little more atypia. And then others actually form apparent glands. And in those instances, sometimes it can be a little bit more difficult for the pathologist to make that diagnosis. And so we will use immunohistochemical stains. And the one that I think all of you are most familiar with is the chromogranin. Patients are generally, I think, followed with serum chromogranin levels, a fair number. We use it as an immunohistochemical marker to identify or confirm neuroendocrine differentiation. And it's a very specific marker. So if a tumor stains for chromogranin, it's almost always going to be a neuroendocrine tumor of some sort. And we're looking at the brown stain here, staining that cytoplasm. Now, not all tumors stain with chromogranin, so we have a backup to immunohistochemistry stain that I show on the right, that's synaptophysin. It's not quite as specific. Some other tumors may stain for synaptophysin, but it's a very good backup marker. Now, this is an immunohistochemical stain. Again, we're looking at the brown reaction for glucagon. Remember, I mentioned some tumors secrete hormones, and we can stain some of these tumors and identify the hormone product. But I want to tell you that whether a tumor is considered a glucagonoma would be based on patient symptoms and serum levels. It's never anything that we would do. All we would do is be able to confirm that, yes, patient presented with symptoms of a glucagonoma. Dr. Norton, he's going to talk a little bit, removes it. We could stain it and say, yeah, you got it. That's a neuroendocrine tumor, and it's got glucagon, and it's a glucagonoma. But we would never make that diagnosis. That would be something that George or Jeff would make. So the current terminology is no longer carcinoid, as you've gathered. It's neuroendocrine tumor, or some people use the term neuroendocrine neoplasm, and they've been divided into grades, low, intermediate, and high, and they've always been sort of low, intermediate, high, at least in the last decade, but the terminology's been a lot more cleaned up, so that now, going forward, if we if I make a diagnosis of a neuroendocrine tumor grade 1, it's going to be the same diagnosis if it goes across to the East Coast. They'll say the exact same, you'll hear the exact same diagnosis. Whereas in the past, you might get carcinoid, you might get well-differentiated neuroendocrine carcinoma, you might just get neuroendocrine carcinoma, and what does all that mean? So I think that cleaning up the terminology and making sure that we're all using the same classification is a big step forward in terms of prognosis, predicting how the tumor will behave, and in terms of providing George and Pam some information about how they should best treat patients with these tumors. Now, ENETS is the European Neuroendocrine Tumor Society. There's a North American Neuroendocrine Tumor Society. They're NANETS. They haven't really weighed in about whether we're using the term tumor or neoplasm, but I don't think that they could particularly care. The WHO on the far is the World Health Organization, and they've got on board this year with the grading, and they're using neuroendocrine neoplasm. So that's why I'm giving you both. Tumor, neoplasm, that doesn't matter quite as much. So you might hear one a medical professional using tumor, the other one neoplasm. Those are equivalent terminology. So as I say, we're grading them now, and there's very strict rules about how we grade them, and it's based on how actively they're dividing, which makes sense, right? So we actually can count mitotic figures using just a regular H&E stain, and then we can also do an immunohistochemical stain that is sort of a surrogate for proliferation, and this is the Ki67. You'll also see it referred to as MIB1. And these are the cutoff thresholds now, and so this is also, as I say, standardized throughout the GI tract. So grade 1 tumors will have a very low mitotic index, less than 2 in 10 high-power fields. The grade 2 tumors will have something between 2 and 20, and then the high grade, the neuroendocrine carcinomas, and that's the term that we use now for the grade 3 tumors, are going to be a high mitotic. And I keep forgetting to correct that. That should be a greater than 20 on the right. I've given this talk 2 days ago to the residents, a version of this talk, and I forgot to fix it. I'm sorry about that. And then we also do the Ki67. Sometimes patients present with metastases, and we only have a very small biopsy, and it's easier sometimes to be able to come up with a more accurate assessment of how proliferative that tumor is using a Ki67 than counting the mitotic index. And so we're using both to grade them. So the new AJCC staging, and this really is quite new, this just started this year for neuroendocrine tumors in the GI tract, takes into account the grade, but it also takes into account a variety of other factors as a way of predicting how advanced the tumor is, and how an attempt to predict time to recurrence, and although there are other things that feature into that. And again, this is a good way of standardizing so that when doctors talk to each other, they can. When I mentioned grade 1 neuroendocrine in this stage, they understand, and it's like we're all talking about the same disease entity. And really, there was no staging system before 2010. So we take into account tumor size, which is really not different from a lot of cancer staging systems, depth of invasion into the bowel wall, invasion into adjacent structures, lymph node metastases, and then, of course, distant metastases. So it's the basic sort of staging criteria that are used for all kinds of cancers, but now there's a specific one for GI neuroendocrine tumors. And so this is an example of a neuroendocrine tumor invading into the bowel wall, the muscularis propria, and here down at the inset you're showing invasion into a lymphatic vessel. And that's an immunohistochemical stain that's highlighting the lymphatic endothelium, and you can see there's a little small tumor plug. So now we can sort of, if the nodes were negative but there was lymphovascular invasion, this thought would be there's still a good chance that the disease is systemic because it's in lymphatics channels, even though we don't see it in the lymph node at this point. So this is just a representative sort of table that we would use now, for example, if it was a stomach or a neuroendocrine tumor, we'd report the grade, the mitotic index, and it's recommended that you count lots of fields, 40 to 50 high-power fields. So that's why if it's a small biopsy, sometimes the Ki67 is a little better. the staging, and then all of these other things that I talked about. So in summary, where does the carcinoid tumor fit? Well, as I mentioned, carcinoid was originally thought to be quite benign. In recognition of the fact that not all of these tumors are clinically benign, new terminology has been created. And the thought is that it's predicting as best we can risk for metastases. And I think the three risk categories are really fairly useful for informing current treatment strategies. So if there's any questions, I think we do have a minute or two, and if not, I will be around. And then there's one other thing. I know that a lot of times people have trouble reading their path reports, and they don't understand certain things that are in their path reports. And I'm always available. I think you can find me on the web, or they can give you my email to answer questions about path reports. I don't mind doing that at all. Thank you.
At the patient's tumor cells, how frequently should a patient have their tumors biopsied?
That's a George question.
Whenever George says so.
Yes.
No. So generally speaking, if you have a diagnosis of a tumor and then the disease behaves as we expect that tumor to behave over time, there's no reason to repeat a biopsy unless you need additional information for some of the new targeted therapies that Pam and I might touch on later. But there's no reason to do multiple biopsies. So I guess that's the easy thing. So now, having said that, if you have a tumor that's diagnosed in 1974, in 1985 you have some liver spots, well, we want to biopsy those liver spots to make sure that it's the same tumor, or because it could be something completely different, and that's a situation where we need to do a repeat biopsy.
Right, I would say mostly when we get repeats, it's that kind of situation, or the diagnosis is in question and they can't get the original slides to review and it's not behaving in that right way, or it starts behaving. It looks like the clinical presentation isn't the same. It doesn't fit any known carcinoid. So sometimes you'll have you do get other tumors sometimes. These are indolent tumors, so it's a possibility that you can get a second primary. So I think that's usually when we see second biopsies.
And so if a patient is being seen at multiple institutions, do they need to have their pathology at all institutions? How does that work?
The question is, if the patient's going to multiple institutions, should they have
pathology reviewed at each institution?
My strong and I think it's professional and personal opinion is that every patient should always have a second opinion for any malignant diagnosis. I don't know that the insurance companies will necessarily cover it, but I think it's in patients' best interest to always have a second review at least. Now, if you're going to multiple centers, they'll probably still want to see it, but after a while, if you've got a lot of confirmations, I don't need to know that you need to have multiple, but I'm a firm believer of at least one second corroborative opinion.
I'll just cement that by saying that if this comes from a excellent community hospital where a very good community pathologist has taken a look at the pathology, I would say that you absolutely need a second opinion from an academic person who devotes her career to neuroendocrine tumors, because there are some intricacies. Now, having said that, if a person comes to us from Dana-Farber at Harvard and has a pathology diagnosis, I won't jump up and down because they don't have the pathology. We tend to trust, even UCSF will trust. No, I'm kidding. But if we're going to treat, we do want to see the pathology.
Stanford has a bylaw.
Yeah. So if we treat,
we're not supposed to trust UCSF.
that's from someone who came from UCSF, I want to add. So the truth is,
It's a good, it's a rule in the hospital. It's like you're not supposed to drive over certain speed. You're supposed to be on the side of the street. That's the rule.
so he's absolutely right. So if we treat the person, we have to have the pathology. But sometimes we're just seeing a person's second opinion. If I'm the fourth opinion, having been seen at Harvard, Mayo Clinic, MD Anderson, I might not charge the person an extra $300 for Teri to agree. if everything looks classic. I might go ahead, I say, well, this doesn't look quite right. Terry, can you help us out here? That would be a reason to have a fifth review or fourth review. Go ahead.
And just really quickly, I think the NCCN is really quite interested in the second opinion and business, and I think they've looking into it in terms of making a formal recommendation. So maybe in the next few years, the insurance companies will be coerced, if you will, into paying for at least one second opinion.
I think this is probably a question for the team here. If after surgery for carcinoid, if they found that the cancer had invaded into not all of the lymph nodes, but maybe 10 of 22 of the lymph nodes, what does that mean in terms of the pathology and in terms of the treatment strategies?
Well, from the terms of pathology, 10 of 20 is a lot of nodes, and it's probably not, I wouldn't think prognostically a lot different than, 18 of 20, but George can talk about that.
The more involved nodes, the higher the risk of recurrence. But if all the nodes have been removed and there's no other evidence of disease, that could still represent a cure. And what we generally do is we follow people in that situation. And Dr. Norton might address that specifically because he's one of the experts on that. Should we move ahead?
Yes.
Okay. So thank you, Terry. Thank you very much.